Now we have our last speaker of this very long session that we have in the beginning of this excellent conference. We will present Prof. Kehoe, who is Professor of Gynecological Cancer, Institute of Cancer and Genomic Sciences, University of Birmingham, UK. Dr. Seen is going to talk about the management of relapsed ovarian cancer. Update from the desktop third trial. Please, Dr. Sen.
Shall I start, yeah? Okay, thank you very much. It's a pleasure to be here, and I'd like to thank the organisers for inviting me to speak in this fantastic country, which I've visited on many occasions. I'm going to present to you probably it's one of the more important trials, but it's a surgically based trial, slightly different to what you've probably been listening to today. And I have to acknowledge the fact that I'm very grateful for Andreas Dubois, who is a professor in Germany, who gave me these slides and said, yes, Sean, you can use these slides. But he's the CI of this trial, looking at the management of women with relapsed ovarian cancer. In many cases, as you can see, a lot of very few women, if you like, relatively speaking, to such as breast cancer, do actually develop ovarian cancer. But most of the patients will succumb to their disease, and most patients present with advanced disease, and relapse is extremely common. Managing relapse disease, you have various choices, of course, going from end-of-life care to prolonging survival, just to symptom relief, but most importantly, maintaining the patient's quality of life. It's unlikely that you will ever cure these patients from the relapse. And therefore, the standard of care that we used to have was that of giving these patients chemotherapy at relapse, not necessarily automatically operating on patients unless there was reason for symptomatic relief. With chemotherapy, we've known over the years in ovarian cancer that the longer the gap or duration between the first time you're exposed to chemotherapy, the greater the response rate subsequently. Therefore, if you give somebody chemotherapy 7 or 8 months following their first course of chemotherapy, they will not do as well as patients who've had 12 months non-treatment interval. This is probably a reflection of the biology of the tumour, and as shown here, the treatment-free interval correlates directly with your survival of second-line therapy. And this was done many years ago, looking at this, by George Blackledge and the group in Birmingham, who were the first to show the fact that the sensitivity in ovarian cancer to platinum-based therapy correlated, or with a direct correlation, with the time frame between first and second therapies. And we do have many therapies presently that we can use in relapse disease. So in the UK, we have a format for primary intervention, chemotherapeutically speaking. We also have a national guidance if the patient relapses within 6 months or outside of 6 months, and a lot of targeted therapies coming in at the same time. But which patients should we look at for surgery? And there had been quite a bit of work done around the world looking at the type of patients that relapse who may well do well out of surgery. And it was felt that looking at these non-randomized studies that younger patients did well. Interestingly, if they had a long disease-free or treatment-free interval, they did better when they had surgery at relapse. And if you could get all of the disease out, what we call optimum debulking at relapse, they did well. In those you considered operating on, if they had unresectable disease, ascites, or a lot of widespread disease at relapse, they did not do so well. And the question was, is this a good thing or a bad thing to do? What should we actually do with these patients regarding surgery? These non-randomized trials that reported, some of them reasonably large, all found the kind of same thing, that the disease-free interval was very important, and the residual disease that was left behind following second operation at relapse, again, was a major prognostic factor. There were more than these, and I just did this myself. These are about 7 non-randomized trials. As you can see here, the survival in months starts to increase when you operate on these patients, and it relates to the disease-free interval. It's quite a strong correlator, and therefore, again, we need to remember here what we're looking at is the biology of the tumour. The Cochrane database also looked at this with regards to surgical site reduction for recurrent epithelial ovarian cancer, And as they said, in platinum-sensitive recurrent ovarian cancer, the ability to achieve surgery with complete cytoreduction is associated with significant improvement in overall survival. But this, of course, was gleaned from the information that was available, but there was no real randomized trial to tell us how should we manage these patients. And the trial I'm going to show you now has not been published yet. It was just presented in ASCO last year. And this trial tried to address this important question in the management of these women. Andres was the CI of this study. And preceding this, it's important to note that the selection criteria were involved in another study called Desktop 1. Then they were validated, called Desktop 2. And then this randomized trial came. So there's an awful lot of work preceding this trial in deciding what kind of patients should we consider operating on, where we might do them some benefit, and then let's randomize these patients and see what happens. So, as I say, surgery and chemotherapy, as I said, are the cornerstones for ovarian cancer, but we don't have a defined role for the management of these patients, surgically speaking, at relapse. And as I said, the Desktop 1 was developing this hypothesis that we sort of knew about, and from that this score was derived, where patients had a good performance status, where they had complete resection at their primary treatment, and they had very little ascites. And from that score, this is how the patients were selected. This was validated, as I said, in the Desktop 2 study, and it was felt that you could actually select patients out of relapse who could benefit possibly from not just having chemotherapy when they relapse, but also addition surgery, which is done electively. All of the patients obviously had written informed consent with ethical approval for the study, central randomization, and importantly, the main endpoint here was overall survival. And whilst a lot of statistics were undertaken, it is important to realize that's the main endpoint. Secondary endpoints of importance were progression-free survival, resection rate, and treatment burden. We will come to this as we go through the study. So the patients had first relapse. They were then randomized with a target of 408 patients, either to have cytoreductive surgery, followed then by platinum-based chemotherapy, versus no surgery and just go directly to your platinum-based chemotherapy. There are 80 centres, as you can see, in 12 countries, which is always a good thing to see. The more widespread studies are done, it is beneficial. And the recruitment occurred over 5 years, though there was a preceding quite a few years of the work with the Desktop 1 and Desktop 2. When we look at the populations in this randomized trial, there were no significant differences between the two cohorts. The age in years is roughly about what one might anticipate for patients who are in relapse. The vast majority of patients had advanced disease, that's stage 3 and 4, and high-grade serous carcinoma constituted over 3/4 of the patients in the study. And the high-grade serous is probably the main one anyway that we really want to target with regards to chemo and surgery. Most patients were given some form of platinum-based therapy, but again, no significant differences between the two. And the treatment-free interval, the median treatment-free interval, was 18 months in the surgery and 21 months in the, 18 months in the no surgery arm and 21 months in the surgery arm. So these are patients, if you like, with quite a good disease-free interval. It's important that because when you're going to apply this study, you have to select these patients appropriately. The platinum was given to the vast majority of patients in both arms, with, of course, the targeted therapy, such as bevacizumab, again, being very popular use, particularly on mainland Europe. It's less so used, I have to admit, in the UK. There was quite a severe attempt, if you like, or a prolonged attempt to make sure they could get patients down to no residual disease, and that's reflected by the median time spent at surgery, which was 220 minutes. A third of patients, as you can see, had bowel resection, with 3% having diversionary procedures, blood transfusions, 1 in 5 patients, and as you can see, the not unexpected postoperative problems that you would anticipate in these type of procedures. One of the things that was noticed was that the disease-free interval of the overall survival in this study was not achieved as yet. And part of the reason for that is because patients did better than they thought, which is not uncommon in trials, because there is an element not just of selection of patients, but of patients selecting themselves to come into the trials as well. Nevertheless, it was worked out that 122 events were required for the overall survival, and at this point in time, they hadn't reached that significant level so far. It was discussed at the independent board for the study, and it was felt it should continue on, but there was some information that could be released with regards to the outcomes in this important trial. And this was the finding so far, that the progression-free survival in patients with relapsed ovarian cancer in this select population, when you undertook surgery, you influence their progression-free survival significantly. Now, whilst we still have to wait for the overall survival, the argument here, which is a reasonable argument, is that change in progression-free survival, if it was a new chemotherapeutic regime, would be taken very seriously in this setting. And therefore, this is very, very a positive finding, albeit that we still have to wait for the overall survival. But this, again, is the first study ever to show that in women with relapsed ovarian cancer, that you consider operating on them and you can offer them at least an improved or a prolonged progression-free survival, which I believe is actually very important in this type of disease. The other thing they looked at was subgroup analysis to see how did patients do with relationship to having no disease after surgery versus some disease left behind after surgery. And this seems again to reflect what's been found when you undertake primary surgery in ovarian cancer, in that those who have no disease do better than those who have some disease left behind. And this is an enormous pastime, I would put it this way, that we undertake in gynae-oncology, always looking at who does better than the other. But it's just an interesting finding to be noted. And again, if we look at the treatment-free intervals, again, we find with surgery, the patients had a longer period of time where they did not need tertiary intervention in the arm where they had surgery and chemotherapy versus those who had no surgery. Again, I point out this could be of importance in its own right. When it comes to the mortalities, they were equivalent in both of the studies. Interestingly, in those who had no surgery, there was an increased incidence of leukopenia and neutropenia, which seems counterintuitive because you would have thought following surgery that might be a little bit more stressful on the body in certain ways. But it was just one of those findings that is statistically significant and needs to be highlighted. But the rest of the morbidities were equivalent in both arms. So from this study, and as I say, it's the first in the world to have done this, it shows that secondary cytoreductive surgery in this patient population, I have to stress, revealed an improvement with surgery as part of the management, the routine management of patients, to enhance their progression-free survival and their treatment-free interval. The major benefit was seen in those patients where all of the disease was removed. If disease is going to be left behind, unfortunately these patients do not seem to do well. And as Andreas has said, it's important therefore that where these patients are going to be managed, that you have surgeons or gynae-oncologists who are prepared to spend time and see can they actually remove all of the disease in these patients. There's always this concern that some of the patients are being seen by gynae-oncologists who themselves do not push forward that effort or may not have been trained on the much wider type of surgery that's required for some of these patients. And that's not unreasonable, but for this type of a study, you do have to push for that complete clearance of disease. And unfortunately, as I said again, the overall survival is awaited. But we do know from prior studies that the correlation between progression-free and overall survival is reasonably tight in ovarian cancer. It's not like some bowel and breast cancer situations whereby progression-free survival, the tightness of the correlation between the two isn't 100% to say the least. These are all the groups that were involved. As you can see, there's quite a large group as well in the UK who are putting patients into this study, and it did recruit extremely well. So is management changing because of this? Well, I think we can state at this stage, and we'll have to wait for the paper to be published before we change any practice, is undoubtedly progression-free survival can be prolonged. Chemotherapeutic agents are probably also understandably contributing to this prolongation. But we need to be even more sophisticated in selecting patients based on their molecular or tumour molecular markers and also the targeted therapies. And the reason I kept stressing about the treatment-free interval being prolonged, the progression-free interval being prolonged, is I believe that we're probably heading into a situation with ovarian cancer where we're looking at managing these patients as a chronic disease. As we all know, the philosophy that is for the management of cancer has always been twofold. One is we give treatments to cure the patient, which is good, but has always been the philosophy of, is there a case to be made where we manage the patient, where they have good quality of life, but they still have their cancer? And I suspect that's what I'm trying to emphasize here, is that for this cohort of patients, we're moving into that era. I never thought I'd turn around to patients and say, you know, should I have third-line therapy? I said, I would wait, because the volume of new targeted therapies coming out, the trials are going so fast. By the time you're finished that, if you buy another year, it's quite possible to have another therapy for you. And that's a huge shift that's occurring, where I believe that in ovarian cancer, we're going to have a cohort of patients who are managed as a chronic disease. We won't clear their disease, they will live with it. Most importantly, hopefully, they will have good quality of life in that situation. And this desktop trial, if we just accept the progression-free survival, I believe is contributing to that for a cohort of patients. And that's what makes this study quite important in the field as a surgeon from the ovarian cancer perspective. So, as I say, I'm very grateful for being able to present that to you. And the paper will go in and be published. Don't change all your practice at the moment. But nevertheless, if you have a patient who's got relapsed disease, it's not unreasonable to say, we have preliminary results, I'd like to give you that option if you would like that, or you can just have your chemotherapy if you wish. So you are kind of entitled to do that because this has all been ethically approved. But it would be nice to see the final paper, and in particular, the overall survival. So this is a big change, I believe, in ovarian cancer in the relapse setting, and I'm not aware of any other study that's out there yet to confirm this, but I believe it is a bit of a game changer, proving again that surgery has a very, very important role in this disease type. So I'd like to thank you very much for your attention. Thank you.
Thank you so much for this excellent presentation. And now the floor is open for a couple of discussions, just for the sake of time. Any questions from the audience? Can we have a microphone, please?
No, we can't hear.
No, we can't hear you.
Would you like to come here?
اهو خدت جاي لها ميكروفون.